Good evening, everybody. At first, I'm very happy to be with you today in such elegant conference, and thanks for the organization committee for inviting me, and for all participants and attendees of this conference. My topic today is about the incidence, risk factors, and outcomes of acute kidney injury in hospitalized patients with COVID-19. Introduction. COVID-19 remains an ongoing pandemic illness. It continues to pose huge challenges to countries and healthcare systems worldwide. Although COVID-19 is a primary respiratory illness, it has been recognized to affect other organ systems, including the heart, brain, endothelium, and the kidneys. There is a growing evidence that acute kidney injury is a common and significant complication with substantial morbidity and mortality among hospitalized patients with COVID-19. The pathophysiology of AKI in COVID-19 patients involved different mechanisms, with the most predominant reported histological feature being acute tubular injury. Although many risk factors have been identified and approved to be linked with complication of COVID-19 infection, however, the risk for specific complications like AKI still needs more research. The incidence, risk factors, and outcomes of AKI among COVID-19 hospitalized patients remains unclear, with significant variations among centers and countries. Many studies emphasized upon the association of vitamin D hypovitaminosis with the risk of chest infection, ARDS, AKI, and even more. It could be implicated to worst outcome and mortality in critically ill patients. Very recently, the role of vitamin D deficiency as a risk factor for susceptibility and severity of COVID-19 has been highlighted. However, its exact mechanistic pathogenesis and its relation to other risk factors have not been fully understood. The aim of our current study. In the current study, we aim to assess the incidence, risk factors, predictors of AKI and outcome in COVID-19 patients admitted to hospital, trying to know why some patients got this serious complication, and are there any factors that can affect the outcome of such patients, as well as factors linked with higher rates of mortality. Subjects and methods. In this retrospective cohort study, we included 103 cases of adult patients over a period of 6 months. All patients were admitted to internal medicine wards or ICU, and were confirmed to have COVID-19 infection. Of course, an informed consent was obtained from all our participants. Patients who received hemodialysis before hospitalization were excluded from the study. Patients who did not have serum creatinine drawn at the time of hospital admission were identified and also excluded from the study as well. Data collection. Of course, detailed clinical information of each patient was obtained, including the demographic data, medical history, comorbidities, symptoms, signs, and laboratory and imaging findings. The primary outcome of our study was the development of AKI, and the secondary outcome was 30-day mortality in the group with AKI and the group without AKI. AKI was diagnosed by the increase of serum creatinine according to the KDIGO guidelines 2012. The urine output criterion wasn't used for diagnosis of AKI since nursing records were out of reach in COVID-19 areas. The baseline serum creatinine level was defined as the minimum inpatient value during the first 7 days of admission. Sample collection and processing. Of course, we withdrawn 10 ml of venous blood sample collected from each patient by sterile zone puncture. Serum samples were used for assessment of basic biochemical parameters, including the fasting blood sugar, postprandial blood sugar, lipid profile, calcium, phosphorus, blood urea, serum creatinine, and albumin as well. EDTA collected samples were used for hematological studies, including the complete blood count, hematocrit values, and of course, the vitamin D assessments. Urine samples were collected in a sterile polypropylene container for urine analysis, physical, chemical, and microscopic examination of the urine samples. The SARS-CoV-2 PCR testing, the confirmation of COVID infection for our patient of included patients was done by the approved protocol for nasopharyngeal swabs collected and transported in viral transport medium in a single tube as stated by the WHO, according to the shown kits. Our results. Table 1 shows the socio-demographic, clinical and lab data of the studied cases, and with all variables shown as mean, standard deviation ranges, and percentages as well. Table 2 shows the COVID-19 patients' characteristics with and without AKI. We found that high significant difference between patients with AKI and non-AKI regarding age and temperature, total leukocyte count, renal functions, blood urea, serum creatinine, and GFR, albumin, fasting blood sugars, and the presence of cast, pus, and the presence of chest complication, vitamin D deficiency in our patients. Table 3 shows the univariate analysis for factors affecting AKI on COVID-19 patients. We found that age above 60 and temperature above 38.5 and total leukocyte count above 10 and blood urea more than 40 and GFR less than 90, albumin more than 3.5, the presence of chest complication, vitamin D deficiency, the presence of cast or pus in the urine analysis. All these factors are significantly associated with AKI in our in COVID-19 patients. The multivariate analysis for risk factors of AKI in COVID-19 patients, we found that the presence of chest complication, the presence of vitamin D deficiency, and the presence of casts in urine analysis are the most significantly associated with AKI in COVID-19 patients. Table number 5, this is a very important table. It shows the factors affecting the severity of AKI in COVID-19 patients. We found that the most significant factors that affect the severity of AKI in our patients and associated with moderate to severe cases of AKI in COVID-19 patients were body weight, diastolic blood pressure, respiratory rate, albumin, LDL level, and the presence of chest complication and vitamin D deficiency. Table number 6 shows the risk factors for mortality in COVID-19 patients. This is a very important table. We found that age more than 76 and the presence of AKI and heart rate more than 90, hemoglobin less than 9, temperature more than 38, serum creatinine more than 1.8, blood urea more than 42, GFR less than 65, LDL more than 136, the presence of casts or pus in urine analysis, and the presence of chest complication and vitamin D deficiency, all are highly significantly associated with increased mortality in hospitalized COVID-19 patients. This figure is a very important one. It's a ROC curve. We have tried to identify a predictor of AKI in COVID-19 patients. This figure showed that vitamin D at the cutoff level below 23.5 and GFR at the cutoff level below 77.5 and albumin below 3.3 level. They are very good predictors of AKI in COVID-19 patients. This figure is a very important one. It's a ROC curve of vitamin D for prediction of mortality in COVID-19. We have tried for the first time to identify a cutoff level of vitamin D to predict mortality in COVID-19 infected patients. We found that vitamin D at the cutoff level less than 19.5 was associated with increased mortality in COVID-19 patients. Conclusions. In our study, we report that 25% of COVID-19 patients admitted to hospital for respiratory support developed an AKI, with 11% of the overall cases died. Risk factors for AKI in COVID-19 patients, including old age, as we mentioned in the results, high-grade fever, hypoalbuminemia, vitamin D deficiency, and a higher frequency of chest complication on chest imaging. Patients with older age, more comorbidities, and vitamin D deficiency were more likely to die from COVID-19 infection. Our results showed that vitamin D level at a cutoff level less than 23.5 milligram per ml and albumin at cutoff level less than 3.3 milligram per deciliter were significant predictors, as we mentioned in the results of AKI in COVID-19 patients. Both risk factors were good predictors of severity of AKI in COVID-19 patients. Severe COVID-19 patients showed more vitamin D deficiency than milder cases, as we shown in the results. Additionally, vitamin D deficiency with levels below 19.5 nanogram per ml was significantly associated with increased mortality in hospitalized COVID-19 patients. And we have highlighted that for the first time to mention a cutoff level for vitamin D that associated with increased mortality of hospitalized COVID-19 hospitalized patients. To the far of our knowledge, this study might be the first one to demonstrate that vitamin D deficiency and hypoalbuminemia were significant predictors of AKI severity and mortality as well in patients infected with COVID-19, and define a clear cutoff level for both. Vitamin D, this is our recommendation. We recommend that vitamin D should be measured at a routine test in all hospitalized COVID-19 patients. We understood that limitation in our study, like the relatively small sample size and the observational nature of the data, are factors that might affect the study results. Further, multi-center prospective studies with a larger sample size are therefore needed, particularly to investigate the incidence of vitamin D deficiency in COVID-19 patients and its association with AKI severity and mortality as well. The world after COVID-19, as we have all saying all the time, the world after COVID-19 is not the one we know before COVID-19. So we recommend conducting worldwide multi-center collaborative research projects to study the long-term consequences of COVID-19, not just the medical ones, but also the psychological, social, financial, and lifestyle modification consequences of COVID-19 infection. These are our references. And thanks for listening. Thank you so much.